Bismillahirrahmanirrahim and Assalamu alaikum. It's an honor and pleasure for me to be invited to talk in this MENA webinar regarding primary prevention of diabetes. I'm very grateful to the organizers, especially Nadima and Mutina, for considering me for this important topic. Way back 1921, 100 years ago, Jocelyn, who was a visionary in diabetes, he has written that now because medicines have come, it's now time to devote attention not alone to treatment but to prevention. When there were only 500,000 people with diabetes in United States of America, so important and so pertinent this fact is more than 100 years ago that we need to concentrate on primary prevention of diabetes. I'm talking about Pakistan perspective 1994 to 1998. Professor late Abdulbasit Shera, may Allah bless his soul, he did the survey and had 20% of diabetes and IGT together. We then did metabolic syndrome study and it was 49%. Metabolic syndrome was trendy in those days, like pre-diabetes or whatever, around 50%. Then we went to a village which is called Hub. In fact, it's an area which has got 16 villages, and we screened 16 villages in total. And we looked at the age between 15 to 25, and what we found is that the obesity had tripled in that same population from 2002 to 2009. This was very frightening. So we went to school children and looked at childhood obesity. 8 to 10-year-old children, 9.8% overweight, 4% plus obese. So what we then suggested at that stage is that 9.6 million children are overweight and obese. Main reason is poor consumption of fruits and vegetables and high consumption of aerated sweetened drinks. And we wrote to the ministry at that stage, high prevalence of obesity and associated risk factors in urban children in India and Pakistan. This was between me and Anup Mishra from India, Delhi. Highlights immediate need to initiate primary prevention program for diabetes and coronary heart disease in schools. Then we embarked on this study. This was courtesy of late Akhtar Hussain. May Allah bless his soul. He was pivotal in this study along with Graham Hitman from UK to look at the genomes and the lifestyle protectors for fetal outcome. And lo behold, our primary prevention shall start not from school age, but from when the baby is in the womb of the mother. What is called like primordial prevention we shall talk of. Healthy mother, healthy baby, without IGT, without diabetes, without programming for diabetes as childhood. And this GIFT study was supported by European Union, and we developed this calendar. And though it's now 11 years ago, I still feel the messages in the calendar are one of the strongest I have seen. One is this: these are traditional Asian sweets. So life is more sweet without sweets. You do not need a beautiful place to walk. You need a pair of shoes to walk. The color of health is green. The more you eat green, vegetables, etc., high fiber, vitamins, etc., anything. Let your weighing scale smile. We feel that it smiles at 100 or 90 kilos. No, it smiles at 60. I've started to say in Pakistan that the weight of Pakistani nation as such, whose average height is between 5 to 6 feet, shall be between 50 to 70 kilo, full stop. Every inch increase in your waist will increase the chance of getting diabetes. And from the beginning, as I said, primordial. So important it is to give these messages for primary prevention of diabetes, that it starts from young age in utero, and it is obesity related. And look at this, early signs of diabetes in children. This is Pakistan. Number of children with high BMI, as we predicted, more than 10 million children. If nothing is being done now, then 2035, the prediction is 28.5 million children will be overweight and obese, i.e., on the verge of developing diabetes, and what not with diabetes and its complications. So we did this national survey in 2016 and 2017 under the patronage of late Abdulsamad Shia, Rahmatullah alayh. And then this is what we found. This is the Diabetes IDF Atlas 2025. And Pakistan is fourth with 34.5 million people with diabetes and will progress if we continue at this stage and this speed. In Pakistan, we had a landmark event, Pakistan Diabetes Leadership Forum, which invited people from Ministry, WHO, IDF, WDF, our Diabetic Association, policy makers, and we had these four keynotes: capacity building, primary prevention and awareness, policy planning and advocacy, and diabetes care program at national level. Mind you, for primary prevention, you need multiple stakeholders. You need each of these. And so capacity building, you need to train diabetes educators. You need to train diabetes counselors. You need to treat behavioral therapists, psychotherapists, etc., and whatnot. So you need educators to be trained. You need Association of Diabetes Educators. This NADEP we created in 2010, which is National Association for Diabetes Educators of Pakistan. We run diabetes educator programs. We involve celebrities. We involve masses and awareness programs amongst the community. And we have now started training the nurses as well. Nurses are a very important component of healthcare system of any country, especially the lower the resources, the more the resource constraint, the more important it is to train nurses, allied healthcare professionals for diabetes and for primary prevention of diabetes. And this is our champion lady. Everybody now knows her in the region. Iram Ghafoor, who is now running not only our WDD campaigns, but basically in the last 2 months in Bangkok, she was elected, officially elected as the Vice President of IDF, for which whole country is proud of, and I'm sure whole region is also proud of. Coming to primary prevention and awareness, this study was conducted with the courtesy of University of Oslo, Professor Akhtar Hussain, the past president of IDF, may Allah bless his soul, and we did a study in Pakistan to show whether intervention of lifestyle works in Pakistan or not. And yes, it works as it in any other setting, in any other country. We know about diabetes prevention program, diabetes prevention study, stop, NIDAM, etc. The same worked in Pakistan for lifestyle changes, and the risk reduction was 71 to 76% with intervention. So by these studies shown up to you so far, we have developed this risk score. This is pioneering work of Professor Musarrat Riaz, now the professor and head of Department of National Institute of Diabetes and Endocrine. This risk score, this has only 3 questions. 30 seconds it takes to come to get your score done, and it is about age, waist circumference, and family history. If the score is 4 or more, you contact the doctor because you have got diabetes risk. Such a simple score. 30 seconds and you know your risk. IDF came up with an idea that if Finland can develop a score, Germany can develop a score, Pakistan develops a score, Denmark, then why not have a global risk score? And so this steering group was made in 2030. And it has people like me, Stephen Collegidy from Australia, Edward Gray, Kamlesh Kunti, Johnson from Denmark, Jakob from Finland, and David Whiting from IDF. And what was the decision? The decision after nearly 2 years of deliberation and meeting was that because of ethnic differences, geographic differences, differences of maternal childhood programming, one global score cannot be developed. It has to be basically country wise or ethnicity wise. This is like we have diabetes talk program initiative in Pakistan. These are various towns in which these billboards have been produced with the courtesy of the government having the diabetes risk score. And so this is an initiative taken on the basis of the risk score. Now we have developed diabetes prevention and early detection program. This is called PARC DPP, PARC DPP. And yes, I am honored to be the main person writing the program. We have a steering committee with Arshad Hussain, Abrar, Asma, and Nazish. Nazish, I would say, is the main pivotal lady behind, who is arranging the camps, getting the screening done, and then putting in the data, etc., etc. I wish this can be rolled out at a larger scale with the courtesy of the government. Coming to policy planning and advocacy, you cannot have primary prevention unless multiple stakeholders are involved. Like this issue of raising the taxes on the sweetened sugary beverages, So I and from platform of DEF, we wrote to FBR, then we got this letter signed by our honorable IDF MENA region chair, then IDF president, etc. And we were suggesting to increase the FED amount to 20% and health levy bill 1 rupee per 250 ml of bottle we suggested. And can you imagine that a country like Pakistan, poor resources, low GDP, very low expenditure on health, they drink 55 billion bottles per year. 55 billion bottles per year. So 1 rupee tax addition will give a revenue of 55 billion. And taking this FED to 20% a revenue of 60 billion. Uh, we are lucky that the government has approved part of it. We hope to increase it further with the fullness of time. Now, these are two busy slides, but very important slides. This is comparing the whole MENA region. So the green is the work done already. And in Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, UAE, you can see all green ticks or only one, occasional red tick. So this is like recent national risk factor survey, set of time-bound national targets for NCD, operational policy strategy, vertical programs, policies, strategies, vertical programs for overweight, obesity, for diabetes, for physical inactivity, evidence-based national guidelines for management of diabetes, availability of basic technologies, diagnostic one, availability of medicines and insulin, presence of national diabetes registry. And so here I would ask the question, with this group one people, with having all these on board, how strongly is your primary prevention program working? This second group is less than the first group with the same headlines, but you can see in Egypt there are two red cross, in Iraq there are two red cross, no red crosses in Iran, Jordan two crosses, Lebanon, Libya, Morocco, Syria, Tunisia, Palestine. And so we can say to a certain extent that resource constraint does affect having national policies. And when it comes to places including Pakistan, you can see the whole screen is red. No national policies, no national targets, no national registries, etc., etc. And this is the state of affairs which worries us the most as being part of the MENA. Coming to other policies like policies on marketing of food to children, policies to reduce salt consumption, policies on saturated fatty acids, policies on saturated fats, policies on trans fatty acid elimination, specific measures to ban industrial trans fatty acid, taxes on sugar sweetened beverages. And look, again, these high income groups, very few reds, all are black. And when it comes to upper middle income groups, red starts pouring in. And when it comes to lower middle income groups, where Pakistan is also there, it's all red, unfortunately. Same with low income countries. So the question which comes is, if this is the state of affairs, do we expect that high resource countries in MENA region shall have more better results in primary prevention compared to the low middle income countries? One is, I do not have data, and I am not sure whether any will have data to show that their diabetes prevalence is going down. I know that each time the atlas comes in, uh, rates are going higher for diabetes, may it be Saudi Arabia, Jordan, Morocco, Egypt, or Pakistan. So, all inclusive of all income countries. Does that mean that policy making is also one of the options or one of the issues identified, but that is not the holistic picture for primary prevention success stories? You need more in succession, and I think that is what I'm saying from the start. You need multiple stakeholders to play their role. Like this, what we did with Rapid Score is we contacted Pakistan Telecommunication Authority to send this message through the mobiles to hundreds of people. 10 million people were approached, but one message given once to 10 million people is not enough. You need a national level bombardment of this concept that diabetes is preventable. This is the rapid score for screening. This is what you shall do if you are in the high risk. Importance of obesity, importance of reducing weight in primary prevention, etc. etc. Now, in this day and age of technology, time has come to realize that technology, social media, AI, etc., is going to take over majority of the awareness programs, campaigns, sensitization, knowledge sharing, etc. We shall use these devices like mobile application for primary prevention of diabetes. Finally, I would like to say that for attracting multiple stakeholders, including policymakers, we need programs like Impact. This is a major program supported by NIHR in UK, improving mental and physical health together, and they are having themes of population level interventions, addressing the mental health treatment gap, preventing diabetes, reducing CVDs, etc. And multiple universities are part of it in collaboration. I, in the end, would like to proudly introduce that I have recently joined a network which is called Indus Hospital and Health Network. Now, the beauty of it is what shall be ideally the healthcare system look like. That most of the concentration shall be on youth engagement, frontline health workers, pre-primary care community engagement. Pre-primary care community engagement. This is what Indus concentrates on. And they, when they need help, shall be referred to primary care and public health initiatives. These are having community health centers, they've got mobile vans, they've got boat clinic, and then those who need further help shall be referred to secondary care or tertiary care. The issue in our parts of the world is when somebody wants to do anything in health, he comes up with a major idea, not minor idea, major idea, i.e., build a hospital, tertiary care service, angiographies, for example, robotic surgeries, gamma knife, etc. I'm not denying the importance of these things, but are we investing enough in prevention? We have been hearing all our ages, prevention is better than cure. So who will guide for prevention? Are we having prevention clinics, specialty defining preventive diabetologists? One is clinical diabetologists. Why not we have preventive diabetologists? Why not dietitians, educators, allied healthcare professionals are trained for primary prevention of diabetes? So my mission now joining this big network is to ensure that we are able to have one Indus Diabetes Endocrine Center looking after community services, primary care setups, secondary and tertiary care setups. And at present, we have around 100 plus primary health setups and four major hospitals across the country. And the first mission is to standardize and streamline diabetes care, including prevention of diabetes at this network. I think I shall stop here, and I'll be thanking the role of multiple stakeholders involved in helping us out in this National Diabetes Prevention Program. There are national institutions and international institutions and collaborators which collaborate with us and whom work I've shared with you. I am very grateful once again to the organizers for inviting me, to you for your patient listening, and I'm available for question and answer. And I finish here by saying it is amazing what you accomplish. If you do not care, who gets the credit? Thank you very much for your attention.